Hey everyone, and welcome to this explainer. Today, we're basically putting on our detective hats to explore this incredibly fascinating world hidden deep within our cells. We're going to act as genomic detectives to uncover exactly how raw sequencing data gets transformed into actual life-saving clinical decisions. Honestly, if you or a loved one have ever had a biopsy or a genetic test, this is exactly what's happening behind the scenes. Because in the realm of clinical next-generation sequencing or NGS reporting, just knowing the bioinformatics terms, it's really not enough. We absolutely have to understand the specific clinical interpretation terms that bridge that massive gap between a raw genetic test and a patient's actual treatment.
Okay, let's dive right into this. Imagine you're staring at this massive data set, and boom, you find a genetic variant. You've caught a suspect at the scene of the crime. But, well, that brings us to the ultimate question, right? You found a variant, but is it actually the cause of the disease, or is it just an innocent bystander? Finding a variant is just the absolute beginning of our investigation. We have to prove its clinical significance beyond a shadow of a doubt before any doctor can actually act on it.
To solve this case, we've got a really clear investigative roadmap. First, we'll look at our genetic suspects, then move into the ACMG classification. Next is clinical actionability, then we'll hit genomic metrics, evidence tiers, and wrap it all up with the final report.
All right, starting with step 1, the genetic suspects.
So, the very first major distinction we have to make is figuring out if our suspect is a germline or a somatic variant. Germline mutations are present from birth. They're heritable, meaning they can be passed down through a family, and importantly, they'll be found in a patient's blood as well as their tissue. Now, on the flip side, a somatic mutation is essentially spontaneous, it's present only in the tumor, and it's not inherited. This distinction is absolutely crucial. Why? Well, because finding a germline mutation might trigger family genetic counseling, whereas a somatic mutation points us strictly toward targeted tumor therapies for that specific patient. But honestly, both paths are totally rooted in determining the ultimate clinical significance of what we just found.
And you know, this brilliantly illustrates our next major challenge. Inside a tumor, you are going to find a lot of mutations, but they aren't all guilty. We have to separate the driver mutations from the passenger mutations. A driver mutation is the bad guy actively pushing the cancer forward. It directly contributes to tumor growth. A passenger mutation, though, it's basically just an innocent bystander, or I guess a backseat driver at worst. It's present in the tumor, sure, but it plays no significant role in the cancer's progression. As genomic detectives, we are hunting exclusively for the drivers because those are literally the only ones with true clinical significance.
When we're investigating solid tumors, our usual suspects often come from a pretty well-known list of genes. If you're looking at a solid tumor panel, you're going to see familiar names like EGFR, KRAS, and BRAF, alongside things like BRCA1 and 2. Understanding the specific hotspot variants, which, by the way, are just mutations that repeatedly occur at the exact same amino acid position, as well as gene fusions within these genes, is absolutely critical for our clinical reporting.
Moving right along to step 2, ACMG classification.
So, how do we actually formally determine the guilt of our suspect? Clinical labs universally rely on the American College of Medical Genetics, or ACMG, classification system. This groups variants into 5 distinct buckets. At the very top, we have pathogenic, which means there is hard, scientific proof that this variant causes disease. Next down is likely pathogenic, meaning it's probably disease-causing, with like 90% confidence. On the completely opposite end of the spectrum, we have benign, a totally normal genetic variation, and likely benign. But the trickiest one sits right in the middle. VUS, or variant of uncertain significance. A VUS is kind of like having a super blurry CCTV photo of your suspect. You know something is there, but the evidence just isn't strong enough to make an arrest, or, change a patient's treatment.
Which brings us to step 3, clinical actionability.
This right here is a really critical part of our explainer. Identifying a variant is great science, sure, but clinical actionability is where our investigation leads to actual life-saving outcomes. It's all about clinical significance. This isn't just some abstract biological concept. It's the entire connective tissue of our work. Clinical significance literally means the real-world impact of a variant on how a patient is managed and treated. We are desperately looking for an actionable variant, something that might change the treatment plan, or even better, a druggable mutation, which means there's a specific, approved, or maybe investigational drug designed precisely for that exact genetic flaw.
These highly clinically significant, actionable variants basically act as biomarkers. Think of a biomarker as a molecular clue. It helps with diagnosis, it tells us about the prognosis, which is just the likely future course of the disease, or it helps us select the exact right therapy. Some great examples are EGFR mutations, MSI status, or PD-L1 levels. They are predictive markers, telling a doctor whether a patient is actually going to benefit from a highly specific medication.
In a lot of cases, these biomarkers are so deeply linked to a specific treatment that we have to use a companion diagnostic. This is a formalized, regulatory-approved test, like by the FDA, that is absolutely required before a doctor can prescribe a specific drug. For example, a patient has to undergo testing to prove they have an EGFR mutation before a doctor is legally permitted to prescribe the targeted drug osimertinib. The test and the treatment go hand in hand. It makes sure a patient isn't put through a harsh treatment unless we know for sure their tumor has the specific lock that this drug key fits into.
All right, moving to step 4, genomic metrics.
Because a good detective doesn't just rely on labels, right? They look at the hard numbers. Consider this number, 50%. In genomics, this often relates to VAF, or variant allele frequency. VAF represents the percentage of sequencing reads that actually show the mutation. If you're seeing a VAF of 50%, it strongly suggests you might be looking at a germline heterozygous mutation, or maybe a clonal somatic mutation, depending on the context. But here's the crazy catch. We also have to consider tumor purity, which is the actual percentage of tumor cells in our sample. If tumor purity is really low, a variant might slip past us entirely, meaning a patient could miss out on a clinically significant, life-saving therapy just because of the sample quality.
Another totally vital metric is TMB, or tumor mutational burden. This basically measures the sheer number of mutations per megabase of DNA. If a patient has a high TMB score, say 20 mutations per megabase, their tumor is highly mutated. Why does this matter? Well, a high TMB can be a massive predictive marker showing that the patient might have a fantastic response to immunotherapy. This happens because a highly mutated tumor looks incredibly foreign to the immune system, making those immunotherapies highly effective.
Okay, step 5. Evidence tiers.
So we have our suspects, and we have our metrics, but how do we formally rank the strength of our evidence? One of the main ways is using the OncoKB levels of evidence. This system scales from level 1 all the way down to level 4. Level 1 is the absolute gold standard. It means there's an FDA-approved biomarker for that specific cancer type. Level 2 is your standard of care evidence. As you move down to level 3, the clinical evidence is strong but a bit limited. And notice the really sharp drop-off when you hit level 4, which basically just points to biological or preclinical potential, not something you want to base a major treatment decision on just yet. Now, alternatively, when we're dealing specifically with somatic variants in oncology, we use the AMP/ASCO/CAP tier classification. While OncoKB looks really closely at drug approvals, the AMP guideline specifically tiers somatic variants strictly by their overall clinical relevance. Tier 1 indicates strong clinical significance. It's a well-established biomarker. Tier 2 implies potential clinical significance. Tier 3 is for those annoying variants of unknown significance, and Tier 4 is reserved entirely for benign or likely benign variants.
But to apply these tiers accurately, genomic analysts don't just work in a vacuum. They use standardized HGVS nomenclature, which is basically just a universally agreed upon way to write out a mutation at the DNA or protein level, and they cross-reference their findings across massive, essential global databases. We're talking databases like ClinVar, Cosmic, and OncoKB. These serve as the global reference libraries where our detectives verify the historical record and the clinical significance of every single suspect they catch.
Finally, step 6, the final report.
After all this rigorous, complex analysis, we finally reached the conclusion of our investigative journey. The final clinical NGS report synthesizes everything into one critical document that lands right on a doctor's desk. It follows a very deliberate structure. It starts with the basics, patient info, sample details, and crucially, quality metrics to prove the test actually worked properly. Then it highlights the clinically significant variants we found. It formally applies the variant classification, whether that's ACMG or AMP tiers, and most importantly, it all culminates in clinical significance. It basically says, based on this exact genetic flaw, here are the targeted therapies, here is the precise prognosis, and here are the active clinical trials offering hope and actionable next steps.
Which leaves us with this final, incredibly exciting thought. The field of clinical genomics is advancing at breakneck speed. Every single day, these reference databases are growing. As our technology and our understanding evolve, what unseen biomarkers are currently hiding in the data, just waiting to become the next level 1 standard of care? The investigation is truly never over. Thank you so much for joining me on this deep dive into the fascinating world of clinical NGS reporting. Keep questioning, keep learning, and I'll catch you in our next explainer.